Yes. No. Not yet. No.
Okay. It seems to have stopped sharing. Let me go back on Teams. Sharing is paused. Okay, let me try sharing again. Can you see it now?
Yes, we can see it now. Yes.
And can you see, if I go like that, is that the full, can you see the full slide?
Yes,
like
that's perfect. That's perfect. Yes.
Yeah. Yeah.
Okay, cool. So yeah, I was just saying earlier, I will pause for questions because for some reason my computer won't let me see my slides and Teams at the same time. So I'll pause for questions, but I won't be able to see the chat. So someone can just give me a shout if there's any questions. I'm Katherine. I'm one of the ENT registrars at Wythenshawe. And my talk's on HPV in the head and neck. This is actually a talk I gave recently at City Labs. So there was an HPV town hall where they brought together scientists and researchers and clinicians and industry to talk about the challenges we face with HPV. Obviously, it was mainly focused on gynecology, but we got a little head and neck section in, which is really nice. Although I think the colorectal consultant there was a bit disgruntled because no one had, obviously, anal cancers can also be caused by SCC. From HPV positive SCC. So what I'm going to do is give you an overview of sort of patients we see and patient journeys that they go on. And then that will hopefully give some context to look at what challenges we face treating HPV and the future directions for research in terms of what's going on at the moment, what are people working on around the world, what different treatment modalities. As I'm sure you all know, there's two main areas of head and neck where we see HPV. So the 6 and 11 causing recurrent respiratory papillomatosis, and HPV 16 causing oropharyngeal squamous cell carcinoma. And there are other strains that do cause problems, but these are the predominant strains. And it's important to know that 11 is the more aggressive of the two in terms of RRP. So what's a typical patient profile? So RRP is usually a juvenile onset. You can get it in adulthood. It's usually juvenile. Incidence per year of 4 per 100,000, and it's supposedly vertical transmission. I'm not entirely sure, but patients who've had a vaginal delivery seem to be more at risk, but you do have babies that have had a C-section delivery getting it. So although the theory of being transmitted if the mother has genital warts and being transmitted in the birth canal seems to hold up, it doesn't in every case. And then the HPV 16, the peak age is late 50s, which is slightly younger than HPV negative SCC. Again, the incidence is 4 per 100,000 per year, and the risk is increased if you're male, if you're white, and with number of sexual partners. Although that's a very tricky one, it's something we get asked about by patients. I think the bottom line I give patients is, because I'm often there with their spouse, the bottom line I give them is, it's like the cold sore virus. It can hang around for years and years and years. You only get the cancer decades later. And the vast majority of adults at some point are infected with HPV. So it's not necessarily a reflection, on their behaviour. And it's, obviously you want to avoid marital strife at a difficult time in a patient's life. So looking at RRP first, so typical case would be get 3-year-old girl referred with a gradual onset of hoarseness over the last 4 months. She's struggling to project her voice. The nursery staff noticed she's otherwise fitting well and had a normal vaginal delivery. And then she's super, super cooperative. You might be able to get a scope in clinic, but it's more likely that you're going to have a look under an anaesthetic, and you can see some papillomas along the length of both vocal cords. You can see on that right hand side, it's sort of protruding into the glottis a bit. So as she's under anaesthetic, you biopsy it and send it to the lab to find out the strain and confirm the diagnosis. You grade it using the Durkee grading score, looking at the size and extent and the number of subsites affected. You'll have a look down into the trachea to see if there's any tracheal lesions or bronchial lesions. And then this little girl will probably have around 5 debulking surgeries a year for the next few years, and over time things will resolve as her own immune system sort of kicks in. So obviously surgery is not the cure, but it is the mainstay of treatment, which is obviously quite unusual for a viral illness. But this little girl, as I said, she's a toddler, she's going to have multiple procedures, she's going to need time off school. We don't see it so much in the UK, but in resource poor countries, you often see problems with airway compromise or pulmonary hypertension even, if these kids are left for a long time between procedures. She'll have reduced voice quality, and obviously when you are debulking this, you want to try and be as careful as possible to preserve the mucosa, that you've preserved the normal mucosa to try and give it the best quality voice possible. And then there is a risk, small risk of malignant transformation and tracheal and pulmonary lesions, which are far harder to treat because obviously it's very difficult to debride in the bronchi and in the trachea. And as these multiple procedures, again, every time it's a general anaesthetic. There's a lot of different ways to do this. Cold steel, laser, microdebrider, I've seen cryoablation, all sorts of different ways. And it's not really known what the best way is. But the kind of main research question here is how can we reduce the number of procedures and increase the intervals between the procedures that are needed? Because obviously that is going to reduce the morbidity on this patient whilst we wait for their immune system to kick in. Other treatments that are given is most places now give the Gardasil vaccination. There's no hugely strong evidence to show that it improves outcomes, but it's got a low side effects profile, so it's generally what we recommend for adults and children. Cidofovir was really popular in the past. There was a very good retrospective study showing benefit, but then there's been questions about whether it is carcinogenic, and certainly there's been some in vitro studies that have suggested that. So most people, obviously, you're treating young children, most people don't use that anymore. There's immunotherapy. So the main thing for immunotherapy is the bevacizumab, which is an VEGF inhibitor, monoclonal antibody. So that can be given systemically and topically. Studies suggest that are some good responses, but there have been some anecdotal accounts of rebound growth. So it's difficult to know how long you give this for if you're giving it systemically, but obviously you can give it topically as well. It's difficult to follow up these patients because, as I said, the incidence is quite small, but you do see a lot of them, so it feels like you see more of it than there is around. But because there's not that many patients, it's difficult to kind of figure out what's going on and what the trends are. So cruciferous vegetables like sprouts, cabbage and things like that, there's been some suggestions that helps, but again, no strong evidence. So to look more closely at this, there's been a project called the Airway Intervention Registry, which has been going on in the UK, collecting data for some time. And that's essentially looking at sites from all over the country being inputting data on all their patients, just to try and get some good studies looking at a large proportion of patients. Sorry, my doorbell's just gone up. Just 2 seconds. Hi, thank you. Thank you. Really sorry about that. I had a delivery. So that's something to look at in the future, and that's something I will come on to later in my talk. But any questions about RRP to start with?
Yeah, Catherine, what do you think of laser? Which type would you use for RRPs? Is there a difference between CO2, KTP? Is there a
I
lower
think
recurrence rate?
have both been used. I think CO2 is the one more generally used. Again, it's kind of, there's not, what we're hoping for with the airway registry is that we might start to see superiority of one method over another. But at the moment, because these patients, there's not that many patients, and there's quite a lot of heterogeneity in the way they're treated across the country in terms of what methods are used and what the thresholds are for theatre and how easy it is to get them into slots. It's actually quite difficult to know which is better. Essentially, the only reason you're debulking it is to improve voice quality and improve the airway. It's just to keep on top of the disease until it resolves. Because as you know, as a previous slide showed, you can get problems with airway compromise, and that can then lead on to pulmonary hypertension in children. So it's probably just a case of debulking it any way you can, and doesn't really make a difference because it's not really going to affect the biology of the virus. But it'd be interesting to see whether this study shows any difference.
Yeah, are they including comparative trials between the modalities, whether we are microdebriding or lasering it?
No, so this is just a prospective study, observational study. It's just basically, I mean, it's now closed, so we should hopefully get some data soon. But basically, what people have been doing is every time they operate on a RRP patient, they're inputting what the Durkee score was, what method they used, whether they've used any adjunctive treatment, and recording the length of time in between the surgeries, because that's a good marker of how well the patient is doing. Because if you're needing to debulk every 6 weeks, obviously that's a lot more of an issue for the patient than if it's every sort of 3 months or so. So we're aiming for, can you debulk, do less procedures overall with longer gaps in between? So that would be that's how we measure whether something works or not in RRP. That's the only way really to look at it at the moment. So that's what this registry looks at.
Yeah. Okay. My last question is, what would you tell a patient who's asking, is this virus infectious to my other kids, between my siblings? Is that something is considered by any means?
It's really difficult to know because it's one of those things. The other siblings, if they've have the same mother and they've been born the same way, then yeah, they probably are equally at risk. There does seem to be some genetic component in susceptibility. So I know there was a population, I think somewhere in the US, that was quite genetically similar, that all seemed to have particularly stubborn disease. And so there's a question of whether the immune responses have a genetic component. So basically, the HPV virus deregulates T cells in the local vicinity. And that's how the virus is persistent for so long. So there's a suggestion that there is a genetic susceptibility as well as that environmental factor, because obviously everyone's immune system is slightly different, and some people's T cells seem to be downregulated more than others, potentially. But I don't think it's been categorically proven. It's just kind of theories that have then been looked at in vitro. Yeah.
Yeah. Okay. Great. Thank you.
So moving on to oropharyngeal squamous cell carcinoma. So typical patient, you get 44-year-old male. He's got gradually increasing right-sided sore throat for 3 months, and the pain travels to his ear. He's never smoked and he rarely drinks, and he's otherwise fit and well. And you look in his mouth in clinic and he's got asymmetrical tonsils and it feels very firm. So you do a tonsil biopsy, which is positive for SCC P16, which is the marker we use for HPV. Do an FNA neck, because his MRI scan shows right-sided neck nodes, and that's also positive, and his CT test is clear. So then he'd be, I'm sure you've all been to MDTs where these types of patients have been discussed, but it'd be a question of radiotherapy or surgery or both, and obviously you try and go for one more modality. So if you think, if it's a small tonsil tumour and you think you can get away with just surgery, then you do that. Otherwise, chemoradiotherapy. If it's radio resistant or the residual disease afterwards, then you may then need to do salvage surgery. Or if you do surgery and then you find that there's nodal extension beyond the nodes, you might then need to do chemoradiotherapy. And obviously, as I'm sure you guys have all seen in clinic and on the wards, there's a huge sort of array of side effects, of both short and long term, for both these treatment modalities. Chemoradiotherapy is pretty brutal to go through, and then obviously lasting issues. Most patients complain of altered taste and very dry mouth. The chemo can also cause hearing loss and kidney damage. And then obviously surgery, again, is not without its risks. You can get nerve issues, scar contracture, and then obviously all the general issues with any type of surgery, especially if patients aren't fitting well as a baseline. But either way, either one gives a lot of anxiety, it's a lot of time off work. I think it's a very socially isolating treatment to go through, because I think a lot of socializing revolves around eating and drinking, and these patients often really struggle with that. They need a lot of follow-up appointments, and it's a huge financial cost, both for the health service, but also for the patient having to take time off work and attend multiple radiotherapy appointments and things like that. So it's a very high morbidity disease, and actually it's one of the fastest growing cancer subtypes in the world at the moment, in the developed world. So HPV 16, as I said, the incidence is say 4 in 100,000, but huge morbidity and mortality, and also it's a very, very fast growing group. So we're seeing sort of tailing off the more smoking related SCCs, but far more are the HPV positive ones. So it's a big sort of public health issue as well as an issue for the patient. So, but we do know that patients with P16 expression do better. So this is Kaplan-Meier curve. This was actually published quite a while ago now, but essentially, if you have got HPV positive oropharyngeal squamous cell cancer, your survival curve is significantly better than if it's negative, and that's to the extent where they've now altered the staging. So the 8th edition of the staging manual actually downgrades you a stage if you're HPV positive. That has not yet translated to treatment, and that's something I'll come on to in a bit. But yeah, as I said, it's really increasing quite rapidly in incidence. So in the UK and the US, cervical cancer rates are kind of going down a little bit, possibly better awareness of screening and things like that. But oropharyngeal cancer is rising. And in terms of targets for research and future developments here, in terms of P16 specific, there's the PAPHOS trial, which we're waiting for the outcome of, and that looked at whether you can de-escalate radiotherapy in patients who are P16 positive. So that compared P16 positives, they were allocated to reduced radiotherapy intensity or the same. And in terms of head and neck cancers in general, there's a reduced, there's PET-NEC-2 trials looking at whether you can do PET CT scan at a year and then have patient-initiated follow-up. And then there's Torpedo, which has recently closed at Christie, looking at whether proton beam is preferable to standard fractionated radiotherapy for oropharyngeal SCC. And there's also some immunotherapies. I don't know how many of you have been to head and neck MDTs where patients been referred for immunotherapy. So if a patient is palliative, if there's no other treatment options available to them and they're generally fit and well, they've got good performance status, they are referred for potentially PD-L1 immunotherapy. So PD-L1 is a checkpoint in...
Sorry, I don't understand.
Please
use the someone's app.
Sorry. PD-L1 is a checkpoint involved in T-cell stimulation. And obviously, you know, HPV downregulates T-cell stimulation, so that's why anti-PD-L1 works. PD-L1 expression is measured, and if it's high, then you can be eligible for, I think it's the, which ones are they called? Pembrolizumab is the one we give most, or nivolumab. And actually, it's quite interesting. So there's been some trials called Checkmate and Keynote, and they've looked at survival. And actually, you get a survival benefit with these, irrespective of whether you're HPV positive or not. But the patients who do best are PD-L1 positive, high PD-L1 proportion, and also HPV positive. That is the best prognostic combo. But when you look at these trials, you look at the survival curves and they look pretty dire. You think you're giving these people immunotherapy and you're only getting a few months benefit survival. But what that actually that hides kind of what the picture we see in clinic, which tends to be about 75% of patients just will not respond at all. Only about 25% of patients seem to respond to this. And you do get the odd patient who responds amazingly well and does very, very well. You know, the disease melts away. So overall, it doesn't look like much of a survival benefit. But if you're one of the patients who it works for, it tends to work very well. The issue is at the moment, it's only licensed for 2 years. And there does seem to be patients that their disease goes from no evidence of disease to recurring when it's being stopped. I actually talked to a pharmacist who's involved in developing a lot of these. She works in melanoma immunotherapy, but it's very similar to what we use essentially. And their feeling is that the effect of the immunotherapy lasts beyond the time that you give it, and that's why it's licensed for 2 years. So I'm not entirely sure. I don't know whether that's going to change in the future, but that's something to have a look at. But ongoing trials, there's looking at more targeted antibodies and fusion proteins. And then in terms of HPV positive specifically, they're looking at specific vaccines. So looking at different strains of HPV-16, so different substrains, and seeing which are more dangerous and which have better prognoses, and trying to target specific vaccines against those strains. And there's also looking at adoptive T-cell transfer, so getting T-cells which are specifically geared towards that particular subset of HPV-16 that the patient's got, and then giving them those T-cells to kind of cover for their own that's been downregulated. But those are all kind of things that are being looked at the moment. I think, is there anything else that we've looked at? Yeah, there's no, I think that's pretty much all the immunotherapies, well, the main immunotherapies at the moment. So going on to vaccination, which is obviously a lot better now. It has been a bit controversial in the future. So when the UK first, sorry, the formatting has gone a bit wonky here. When the UK first introduced HPV vaccinations, it was only against the HPV 16, and it was only in women. So obviously it didn't protect against RRP, and you're not going to get the herd immunity to prevent HPV positive oropharyngeal cancers. The Gardasil was brought out in 2012 for women, which was great because it protected against RRP. But in 2019, it started giving it to males. I think the issue is, I think there's a lot of the public don't make the link between cervical cancer and head and neck cancer. So I think a lot of parents, a lot of kids who are offered the vaccine don't really appreciate what it means for them if they're not female. So I think there's a lot to be done in terms of awareness. And then the Gardasil 9 was brought out last year, and that's for both boys and girls, and that just covers more strains basically, and it does cover more strains that are specific to our ENT conditions as well. So basically the incidence looks low when you look at it, but actually they're very high morbidity conditions, and very difficult patient journeys, very difficult treatment. And then the main mainstay of research questions at the moment are looking at reducing the impact of treatment. Can you downgrade the treatment, and can you give more personalized treatment as well? And I think that will emerge because there has been a lot of work going on in identifying, being more specific about the specific subsets of HPV, and looking at what that means for the patient and what that can mean for more targeted treatment rather than just blanket targeting HPV 16 or 6 or 11. And I think that is pretty much my talk. So I'm going to stop presenting so I can actually see you, because I feel like I've just been giving a monologue to a computer screen. And take any questions you guys have.
Well, that's a very interesting topic. It's way beyond my remit, so I got really new information today I didn't have a clue about, so thank you so much.
It's okay. It's a very popular exam question. Well, not above, not all the intricacies of treatment and things like that, but it is a very common question that will come up in FLCS and DONS, and so I tried to balance it. So yeah, for preparing for exam, you hopefully learn something, but hopefully the rest of it wasn't too simplistic. Then if you're just starting out in ENT, you can learn something too. It's not all over your head.
Haitham, do you have any questions? And we've got Zarina as well. Do you have any questions?
Yeah, Katherine, I do have a question for you. Thank you for that really interesting talk. Yeah, like Khalil, I didn't actually appreciate a lot about that illness, so that was really knowledgeable. It was really informative as well. If with HPV 16, so if left untreated, what's the sort of mortality and morbidity associated with that?
So it generally depends on the site. We have had patients in the past who have refused treatment, but what normally happens is if treatment fails or if they refuse treatment, I mean, if you think about it, it's in the oropharynx, so they're going to have dysphagia, they're going to have airway compromise, and then it can erode into the large vessels as well.
Okay, fine.
And that's particularly pertinent, I think, in the HPV positive group, because a lot of them are stubborn middle-aged men. Not to generalize. Also, I think you really need to get across to them that the prognosis is generally okay if they can have the treatment. But also, I've seen very elderly patients with oropharyngeal SCC who, as the disease has progressed, they've just sort of gradually faded away. Whereas young, fit patients, the problem is they, the cancer grows and it kind of saps all that energy. But actually, if you're young and relatively fit, then actually you will survive until the tumor grows to give you a blowout or cause airway compromise, or you will get to that stage, and it's really, really awful
Sure.
I don't know if you
So
ever
it's
see-
not that fast growing.
It depends on the patient. It is, so the head and neck cancers, yeah, they can be just as fast growing as any other head and neck SCC.
Sure. Yeah.
So I don't think they're not more benign in terms of what they do. It's just more that they generally, and there are always exceptions, but they generally respond well to treatment. I should have added as well, actually, if you're smoking is less of a risk factor for HPV negative. But if you are a smoker, you do worse with HPV positive than if you're not a smoker. So in fact, they have, when I'm talking about downgrading them, it's they whether you're high risk or low risk, and they look at your HPV status and also your smoking status, because those two things combined. So if the worst is HPV negative, medium is like HPV positive but you smoke, and obviously best is HPV positive non-smoker.
Okay, cool. And sorry, I know you mentioned the grading system towards the start of the talk, but I couldn't remember what it was. Do you mind just telling me?
Yeah, so it's called the Durkee grading system, and to be honest, it's only really useful if you're doing research.
Fine. Okay.
It's a scoring system, and it basically looks at the sites of the of the airway, and so you get various points for having disease in that subunit, and then it's like, is the disease mild, moderate, severe? And then I think there's a point as well if the patient's got stridor or something as well. Don't quote me on that. It's not something you would really be expected to know.
Sure. Okay.
For FLCS, it might be good to just know the general theme of how it works, but you wouldn't be expected to reel it off because it's
Sure. Thank you, Katherine.
That's okay. Oh, I think you're on mute.
Thank you for the talk, and thanks everyone for showing up. I'm sorry about the.
Katherine, can I get a question, please?
Yeah, of course. Go on. Your voice is cutting slightly, I think.
Yeah, Katherine, please. I have a question. If you, in your MDT, early stages of HPV positive, T1 to N0 or N1, would you go through transoral resection and neck dissection, or chemorads or radiotherapy only from the start? Or do you leave it as a preference for the patient's decision?
I think it depends. I think if it looks like they've got... So if you do surgery, there's certain features in the surgery that you would then go on to give chemoradiotherapy. So if there's extranodal spread, or if your margins aren't good, then you would need chemorads, in which case just give chemorads to the start, because then hopefully you can avoid surgery. In terms of the transoral resection, you can do the transoral resections. You tend to try and get a 1 centimeter margin, which sounds a lot when you're talking about a tonsil, but actually if you think about where the tonsil is and the structures that surround it, if you're taking off too much of the surrounding palate, then you could end up with nasal regurgitations or hypernasal speech. So you tend to reserve transoral resection for when it's you're definitely going to be able to resect that without too much of an impact on the patient in terms of their function, and your margins are going to be clear, because what you don't want is to resect it and you're going to try and avoid giving dual modality, essentially. So generally in a young fit patient, obviously you would discuss the options with them. You'd always give them the choice. But if you're looking at, a big tumor going towards the parapharyngeal flat plane, you've got bulky nose that look like they've spread, which you can usually see on the scan, to be honest. The radiologist will usually give you a good idea. Then you would probably steer them towards chemorads.
And we don't know yet if there is any difference between if we started with radical radiotherapy or chemorads and reserving the salvage neck for any recurrence, or starting with the surgery and then giving adjuvant radiotherapy based on the pathology report, right? So I don't think we're yet into the guidelines.
Yeah, it's a difficult one really, because if you do a salvage, that the flip side of that is it's all very well good and saying, oh well, you know, they're going to need chemo rads anyway, so let's give them that. The flip side of that is if they have chemo rads and then you're having to do salvage resection, it's going to be a lot harder. And they're going to have a lot more dysfunction afterwards. So you kind of have to balance that. Also look at the patient, you know, are they going to be able to withstand chemo rads? And obviously, when I say chemo rads, the chemo is usually for the younger patients, so less than 70, or if they're, you know, over 70 but they're exceptionally fit and well, because they've shown that giving chemo rad together concurrently does improve outcome compared to if you give them separately, but it is higher morbidity. So things like strokes, things like that are much higher risk giving them together. So you generally visit that for the younger, fitter patients.
Exactly. Can I ask, when you are with a patient, like breaking bad news, telling them that they have an HPV positive tumor in their tonsil or tongue base, and you're asking this public health question, how did I get this tumor? I'm non-smoker, non-drinker. How would you approach such an answer for this patient regarding an old, you know, carrying this virus for a long time? How would you, I mean, counsel the patient regarding that risk?
It's really difficult. I don't normally bring up the fact, I mean, technically it's an STD. I don't normally bring up that unless the patient specifically asks me about that. But I generally say, you know, it's like a cold sore virus. Pretty much everyone's been exposed to it at some point. And for some strains are just more persistent. Some people are more susceptible. And so, you know, like cold sores, you know, they can go away and come back. You know, like cold sores, you don't necessarily know that you've got it, so it can hang around for decades and decades and decades. So it doesn't mean your spouse has cheated on you. It doesn't mean you've been, you know, promiscuous, or, you know, yes, the incidence is higher with more sexual partners, but, you know, patients don't really need to get into that in these appointments. But I just say, you know, most people have been exposed to it at some point, and you've just been unlucky that you've got your strain, and your genetic immunological makeup has just meant that it's become a problem in you.
Yeah. Do we know any relation between the oropharyngeal and cervical cancers related HPV in women from the stats or any studies? I don't think so, right?
I mean, there's the same strains.
But there is no relation, because from our MDT exposure, I don't think I have been into a single patient, even like a woman or a man, or when there is like a genital HPV tumor and an oropharyngeal one. I don't think, it was very rarely, maybe 1 or 2 patients.
I think it depends on how it's contracted, but also if you think it's a very localized infection, so it's, you know, if you get it in one place, it tends to stay in that place. It's not really a systemic infection.
Yeah.
So it's, you know, I don't think I've seen any patients that have had it in 2 different places. Whether that's because the mucosa is slightly different, I don't know. I suspect we'll find more now. They are starting to more routinely look at the different strains of each particular virus. So rather than just saying, I think, you know, in 10 years' time, instead of saying HPV 16, it will be like HPV 16 23.7 or something like that, you know, and kind of tailoring it to that.
Yeah. And
hopefully if there's a good enough Gardasil uptake, we you know, in 30, 40 years' time, we might start seeing the impact from that and seeing less cancers then.
This HPV-related tumors, oropharyngeal, is related to the other topic, which is the occult primary, right? When we have a neck node as a first symptom, and we FNA it, finding it's an HPV P16 positive. And then we are left with a PET negative primary. And then we ask the patients whether we would need to look into it. We need to have some evidence of pathology from the tonsils and tongue base, right? And then sometimes we advise for unilateral tonsillectomy, tongue base myxectomy versus bilateral, knowing that there is a chance of 10% being contralateral, right? How would you counsel a patient about needing to do such surgery, going bilateral or unilateral in such a unilateral P16 positive neck nodes? Do we normally, or your MDT, do you go for a bilateral, unilateral?
I think it depends on the patient, and I think it depends on the MDT. I think different people have different preferences. So I think you want to think, am I likely to find a primary? I mean, and if I'm fairly certain of where the primary is, do I do a neck dissection at the same time? So the question is, if you don't know where the tumor is and you want to do chemo rads, like, do you do a tonsillectomy and plus minus mucosectomy, or do you take random tongue-based biopsies, which haven't really been shown to be super helpful? But then mucosectomy, you've got risk of bleeding. Tonsillectomies, not great because you've got, again, risk of hemorrhage. Or do you just radiotherapy the primary site? The benefit of finding the site is, so if you don't find the primary, that's not an issue because you can irradiate where the primary is going to be. If you do find the primary, you can have more targeted radiotherapy. So that's a benefit to the patient, even if they're still going for radiotherapy, you can target it more. So it's generally discussed on the MDT. Think about the fitness of the patient preferences. And yes, some MDTs will do the full tonsillectomy, mucosectomy, neck dissection. And then if you don't find anything and there's no adverse features on the nose, you just radiotherapy the potential primary sites. Or if you do find a primary site, everything's out and you sort it. It's really difficult. There is a suggestion, there is a theory that, a lot of patients, you never find the primary site. And there's theory whether maybe you've had this sort of microscopic tumor that's thrown off some mets and then disappeared because it's been cleared by the body's own immune system. So that's another possibility. Sometimes you never find a primary site, and that can be quite hard for patients to get their head around. Quite hard for insurers to get their head around as well, because if you've got an unknown primary, they're like, well, how have you been treated? How are you treated? And it's like we're saying, well, you're 5 years post-treatment and you find there's no evidence of disease, so we consider that, you're sorted. But sometimes patients can run into problems with that as well, so it can be a difficult one to explain.
Yeah, it's another point I would like to highlight for all of us. The way the HPV tumors behave macroscopically when we are scoping these patients, does it look the same as the HPV negative tumors or not? Because how the mucosa looks like in these tumors specifically. If we are scoping a patient and we wouldn't find this white exophytic tumor, how can we appreciate or describe such an oropharyngeal tongue base tumor, which should be submucosal? So how can you assess that, or when would you offer an MRI, for example, or biopsy? I mean, clinically.
So I think clinically, if you see a tumor in the oropharynx, you're going to want an MRI, and preferably before you biopsy it as well, because that will show you the extent of the disease. Because you want to know, is it resectable, and weigh up for the patient whether you're going to go down the resection route or the radiotherapy route. So, for example, if it's a tonsil, is it going into the parapharyngeal fat plane? Is it going into parapharyngeal space? Is it eroding? Is it, wrapped around the carotid? All these questions that you want to know, firstly for staging, and secondly to kind of understand your treatment options better. So you would always get an MRI in these cases. And even if, most people would get an MRI as well as a PET in the unknown primary. you can't tell from looking at it on an MRI or on a scope whether it's HPV positive or not. You normally get a feel from the patient. Just the patient's is usually slightly different profile. You get the odd one and you're like, oh, I'm surprised that's not HPV positive, or you're surprised it's negative. You have to remember, obviously, it's not 100% sensitivity. The P16 is not 100% sensitivity. So, you know, do some slip through that? Probably, yes. So it's, yeah, there's, you generally, but there's no way of looking at it.
Yeah, what I mean is when we take some biopsies of the tongue base and tonsils, it is not this exophatic white necrotic tumor as a primary. It's totally different disease. So whenever we find some asymmetry or doing bimanual examination, palpation of the tongue base and tonsils, it is having a normal mucosa with some asymmetry and hard palpation. So I think we should have like a low threshold when we are scoping such patient looking for a primary, even if they are not having any true oral symptoms, just like asymmetry or surface MRI request, right?
Yeah, no, definitely. I think, I mean, I have seen the HPV positive ones. I've seen them in patients that are really ulcerated and exophatic as well. So I think it depends where in the mucosa it is, whether it's sort of kind of more on the surface or whether it's sort of deeper in. But yeah, you're right. MRI is a very good modality. If you are seeing oropharyngeal asymmetry in a patient who's otherwise asymptomatic, it's you know, in an adult, if an adult's presenting with an asymmetrical tonsil, I would generally get an MRI to have a look. And I've done that in the past where I've had patients presenting, have an incidental finding of a PAP positive tonsil. And again, it's good, you know, if you can't see anything, everything looks normal on examination, again, MRI is a good one to kind of delineate whether there's anything going on in there. Because remember, it's got to be over a centimetre to show up on PET CT. So if it's growing on PET and there is a lesion there, it should show up on MRI.
Thank you. Alexis is asking, would HPV vaccine prevent other head and neck cancers?
No, just the HPV positive ones. But actually, as we're seeing a decrease in smoking, we are seeing a steady fall in other types of head and neck SCCs. But HPV positive is very fast growing subset. But no, the Gardasil will reduce cervical cancer, anal warts, genital warts, RRP, head and neck SCC.
Great, thank you. Any other questions, guys?
Hi, everyone. Hi, Catherine. Sorry, I've missed the actual talk. Very interesting discussions. I just have a comment to add. When you mentioned, Haytham, about how we counsel patients with HPV positive cancers and breaking bad news, I agree with what you both mentioned, but I think there's also a very useful guidance. The BANO have released guidance on how to talk and break bad news to patients and families, and I think it's a very useful thing to check out if you and I can share it on the group. It's certainly useful, especially especially for those preparing for the exam as well, because it can come up in the FLCS exam. So I'll put it on the group if you haven't come across that one. And it's really useful because it's like a question and answer, and asking about all these difficult questions that we can get sometimes in the consultations.
Thank you, Amr.
Okay, I guess it's time to conclude the session. Thank you all. It was a very interesting talk, and hopefully next time will be better attendance.
I mean, it's the day after the strikes, isn't it, everyone? I'm sure everyone is running around.
Yes. Yeah, definitely. And we just said that we have protected time from August every Wednesday, so that hopefully will help a lot.
Cool. Well, thanks for organizing.
Okay.
Thank you. Thank you, Catherine.
So much.
See you.
All right.
Bye. Bye all.